Hi.
Hello.
Hello. I had a heart-stopping moment. There was something wrong with my internet. I couldn't get it started, but all good now.
Very good. I'm bright and early because I'm technologically not very able.
There you go.
So
I've come down right next to the modem and chucked my whole family outside.
yeah, women.
Everybody out. Oh, no worse feeling.
My IT support just needed to be present to set me up.
Fair enough. I nearly got my 10-year-old on it.
Yeah, I've got the light.
Yeah, the light's going to be pretty
I
bad.
can turn the other light on.
I actually think we're live, to be honest.
Oh, are we? I'm going to disappear and come back later because I'm way too early, but
Okay.
You can just mute.
And then stop
Or
the
you can
camera.
turn that off as well.
Yeah.
It's all good.
Unmute.
Good. Okay.
And turn the camera back on. Which hopefully be the right camera.
Yep.
Which is the right camera. And hopefully by then it's dark and your background's not so bad.
Okay. All right. I think I'm sorted.
Great. I'll just stay live on, and welcome to the early attendees. Thank you for tuning in early. I might attempt to go upstairs. I've had some internet issues, so actually I think I should stay down here, to be honest. Hi. Oh, my internet. I had no internet for 10 minutes prior to starting. I just can't hear you though. You might be on mute.
Oh, there we go. Sorry, I had a Word document sitting in front of the.
So there was that heart moment where I was like, I've got no internet. I won't be able to start. What's going to happen? So I was thinking of ringing you and giving you the login, but it's all fine now. So
Okay, cool.
So far so good. And Kate's on here as well.
Okay, cool.
Yeah, so it's all good.
Awesome. Yeah, I was just looking. I was talking. I was like, guys, can you not use your devices tonight, or use Netflix, or just make sure my internet works.
I just told the whole family to go out the front. Oh, I was just like, it's not happening tonight. But I shut down and came back in, and it was fine. So okay, I don't know what happened. I've never had a problem before.
Yeah, no, it's funny, isn't it? It's always the way, isn't it, though, when you've got something on.
Yeah. Oh, yes. So Kate's on here as well, and we I've got a feeling that we are live and not in the waiting room. A button may have gotten pressed there. So yeah, but all good. That's happened many times before and we'll be fine.
Oh, okay, yeah, I can see this session is being recorded, so okay.
We'll edit that for
edited? Oh, I was going to say, cool. Yeah.
Yes.
Good.
I'll get cut and edited. It happens a lot actually. People hop in and press the wrong button. So, but that's all good. You're all good.
Now, what was the button I'm not supposed to press on here? I'm just looking.
I think that's already been pressed.
Oh, I can't see that. Okay, cool.
Yes, so don't worry.
Okay, cool.
It's all good. It's start broadcast.
All right.
And it's normally red. So.
Okay,
Hi,
yeah, I was looking for the big red.
Sorry, he's got the wrong camera. I will. I'm just going to try and switch cameras.
And I'm going to just give you a little practice of your screen. That's it. That's good.
Oops. All right. It's a long time since I've used GoToWebinar.
I know.
All the time, but now being so used to Zoom.
Yeah, that's why I was the same. I was like, what is GoTo? How does this work?
Yeah. It's just been
I know.
I know it's swapped back again. What is it doing?
That would be great.
So just swap back now. Why did it swap back? Webcam.
That's it.
Yeah.
That's great. And can you see now that I've shared my screen with you? We are live. I think the broadcast button was accidentally pushed, so we are live and we have people watching. It's only a couple though, so that's fine.
Okay.
It's been a big afternoon, so that's fine. And thank you all for being early if you're with us at the moment. We're just in our practice run, so thank you. So yes, so I've shared my screen with you. Can you see that little white box now that's popped up on your screen?
So Melissa, if
Yeah,
we log out and then restart, will that? Because I guess it would probably be good to do this practice without attendees. In the room.
Yeah, I'm
That's
reluctant to do that because Jenny.
I've had problems with that.
Yeah, Jenny has done that and has not been able to get back in.
Okay.
So I think probably the safest thing is just to stay here and just run through. So can you see that white box on your screen, Genevieve?
Yeah, I can. I'm just getting my PowerPoint up and ready. Just don't want to show my screen with wrong bits on it.
Sure.
Now that we are live, I just be a bit more careful with what we're doing.
Yes.
And this will be cut and edited for the actual library, so that's fine. And thank you all of those if you're with us that are attending and logged in early. We really appreciate it. We're just in our practice mode, so just bear with us until we're ready to start.
Okay, so can you see my screen there?
Yeah, that's great.
And then can you see when it moves?
Yes, perfect. Learning outcomes, assessing fitness. Yep.
Yep, excellent. Case one. Okay, so this is bringing back memories. I used to use GoToWebinar all the time. It's like riding a bike. Okay.
Yeah.
What we might as well stop the recording for the time being. Now we can always restart that.
Yes, yeah.
Yep. Now just with the polls. Yep. So select the poll, launch it. Yeah, that should be all fine.
Thank you everyone for being with us tonight. We'll be kicking off in about 2 minutes time, so won't be too much longer now. It's always a long minute, that last minute. Okay, welcome everybody this evening. A really important topic tonight, and I'm just so glad that we're holding this event. We've got record numbers online with us this evening, so welcome everybody and thank you for joining us. I'm Melissa Wilkinson from the PHN Education team. I'd like to acknowledge the local custodians of the land in which we're meeting this evening and honour elders past, present and emerging. Just a little bit of housekeeping. We are being recorded tonight and it will be available in the Education Library in the coming days for you to be able to refer back to with a copy of the presentations as well. Thanks to our presenters for that. There'll be a survey poll at the end. Please complete that, it only takes a couple of minutes and we use that to plan further events. So that would be really appreciated if you could complete that as well. And if you've got any questions, I'll ask we will have time at the end of the seminar to ask those questions that you'd like. This is your opportunity to ask those, so I strongly encourage you to please do so and to pop them into the chat box. So it gives me great pleasure now to hand over to Dr. Chris Starling. Thank you for being with us tonight, and I'll let you introduce the rest of the speakers. Thank you.
Great, thanks, Mel. So yes, good evening, everyone. My name's Chris Starling. So I'm the GP Synergy Regional Head of Education for Hunter Manning Central Coast and GP at Raymond Terrace. I'd also like to acknowledge and pay my respects to traditional owners of country. And I'm meeting tonight on Warramai land, and I acknowledge that this is Aboriginal land. So thank you for attending tonight. So the Assessing Fitness to Drive webinar tonight is based or part of what we're doing, a vertical integration project on the Central Coast, where we're having a number of education sessions with all levels of learners, from medical students through to registrars, JMOs and supervisors. And we thought this was such a great topic, we really needed to share it with the rest of the patch. So that's why we're doing it tonight with everyone across Hunter, New England. So tonight we have a great lineup of speakers. So we're going to start off with Honorary Professor Dimity Pond, who's going to give us an overview of some research that's been done through University of Newcastle on assessing fitness to drive in older patients. The main section of the talk will be Dr. Genevieve Yates, who's a GP from regional Queensland and has had multiple different hats over her career, including medical education, medical legal area, leadership, management, you name it. So, which is fantastic. And then we're going to round it all up with a bit of a Q&A session at the end. And we're lucky to have Dr. Kate Cotter on with us tonight, who's a geriatrician from the Central Coast. So basically, during the presentation, there is the chat function. So if I could ask you to put questions into the chat, keeping in mind that try to ask questions as you would in a face-to-face session. We can't answer specific patient-related questions, but we certainly will try to answer some of the common themes that come through in the Q&A session. And now, so I'll hand over to Professor Dimity Pond.
Thank you, Chris. So, Melissa, I might just get you to let me see my presentation.
All good. Looks perfect. Thanks, Dimity.
Okay, so I can see myself.
Yeah.
Yeah.
We can see your presentation, Dimity. It's ready to go.
This presentation's fine.
All right.
Yeah.
I just can't see the presentation very well. Let me see. I can't see it. Sorry.
Sorry, so we've moved on to the second slide, so the dilemma.
Yeah, good. All right, cool. Okay, I think I'm right now. Okay, so I'm going to talk about older people and driving. And what I'm mainly going to do is present some findings from a student research project that one of our students, Erin McKernan, conducted for us a few years ago now. And it's actually going to be published in the Australian Journal General Practice this year. So this is a sort of summary of the dilemma. So we have the older person on one side, and we have a young boy with a ball, and you know, the stop sign, and maybe there's a taxi, and how is the poor old GP going to decide whether that older person can negotiate all these hazards? So here again, I've had this trouble before, Melissa. I can't get it to progress now. Okay.
Yep.
So
Learning outcome. Yep.
Okay. We're going to look at these three learning outcomes, which are actually on the on some of your materials that when you logged in. But basically, we're going to look at the Austroads guidelines very briefly, and think about how we're going to triage our older patients and how to discuss the difficult things with them. So Erin was a year 2 medical student. I think she might be amongst the audience tonight, but she's in year 5 now, I think, and on placement, so she wasn't quite sure she could get away. But when she started with us, she was a year 2 medical student, and she had a scholarship for the University of Wollongong driving project to work on an issue to do with driving. And we picked that she would interview some GPs. So she interviewed 10 GPs, and I'm going to present the themes from these GPs. And you can see that we got ethics approval. So oh yeah, that's better. So we're going to, first of all, look at the challenges that the GP faced. So there were 3 themes, and the challenges was the first of the themes that Erin identified. And you can read these for yourself, but you can see that the context of the assessment is difficult. So everybody is different, and people have different degrees of physical disability, different degrees of experience in driving, and the GP has to take all of these things into account when they're doing a driving assessment. And that's challenging, and we don't have a simple answer to that. And then there are limitations in assessment. So GP 6 says a lot of driving is coordinating complex tasks. And how are we going to know from our sort of office-based tools whether the person can do that? So, and then GP 10 mentions that we have to be very careful about new patients, because they may, if they've turned up for the first time wanting a driving assessment, there might be a suspicion that they have actually failed one somewhere else. I'm just having trouble advancing again. Let's see if I can make that happen. Any suggestions? Oh, yeah. Okay, I've got it. I did it. I just have to hit it a number of times. Okay, so social and emotional implications from the driving problems. So the GP knows this person very well quite often, and they know that that person will be really perhaps socially isolated if you take their driving license off them. So GP2 says you completely wreck their social life, and that's bad for their health as well. But then on the other hand, we have to balance the impacts on the community. And in particular, those fellows who are driving, the male drivers have a particular attachment to their cars, which I think is stronger than it is for women. And it's very challenging to tell them that they can't drive. Yay. So that's a little little example of some of the tests we might do. Some of you will recognise the intersecting pendulums from the MMSE, and the clock drawing test, and the trails A test. And what are you supposed to do? So, okay, so well, what techniques did the GPs do that Erin interviewed? Well, they thought it was important to look at what the family thought, and actually they said the family doesn't want to drive with this person, they probably aren't fit to drive, so that's quite a cue. But also it's really important to talk to the family about what's going to happen when that person gives up their license, so that there's some support for them to get out. There's multidisciplinary involvement, so we might like to refer to our local friendly geriatrician to give this sad news to the person, and we might hear from Kate later about how she feels about that. Or it could be that we ask for an OT driving assessment. They can be expensive, or they can do them on a care plan, which contributes a bit to the funding, and that will give you an official kind of trained assessor's view about whether this person is fit to drive, or if there's any modifications to the car that might need to be done, in fact. And there's the guidelines. We mentioned the guidelines as one of the dot points in our opening, and there are guidelines. Oh, I went past the guidelines, so sorry. That's what the guidelines. Oh, sorry. I'm sorry. I'm really, just keep going forward. I can't make it go back, man. Here we go. Those are the guidelines. My apologies, everyone. If I can drive this a little bit longer. Sorry, that was a terrible joke. Okay, that's the 2016 version of the guidelines. I think there's a later version online now, but I haven't seen the actual solid.
Not yet,
Okay.
but we talked about that later, Dimitri.
Sorry?
I said we'll be talking about that later. It's not yet available.
Oh, good. Okay, fine. Good. Okay, so the next thing is the negotiation process. So this was the third and the most interesting probably of the themes that Erin came across because it's new and it's not in the literature so far. And that is that the GPs negotiate whether to give the person their license or not. So they might say like, I will sign off that you can have a license provided you get the occupational therapy driving assessment. Seems entirely reasonable to me. Or sometimes they work with negotiating license restrictions, kilometre restrictions, so that can work so that the person can still get out and do the basic things. And then there's some communication tips that we got out of that Erin got out of the interviews, and you can see some of them there. If you were a mother with a child on the streets, would you want, someone in your situation with early cognitive impairment to be driving? Or maybe some statistical information, might depend on the patient. Or then talking in terms of balancing the cost of holding the license and maintaining a car. Or talking about, the community impact of having someone drive who might not be as quick with their responses as they used to be. The University of Wollongong project that Erin was funded by actually has developed a dementia and driving decision aid, which you can work through with your patients, or you can get your patients to work through it at home with their relatives. And I've got the website there. And that's the article, which is coming up, as I said. I think it's at the moment they're talking about maybe April or May to publish this article. So thanks, everyone. Oh, we'll move on.
Fantastic. So thank you very much, Dimitri. Yeah, great overview. And I think most of us online would resonate with a lot of those challenges. And I certainly really like the concept of the negotiation. I mean, and that's what I found working with my patients. It is definitely a negotiation. There's lots of grey areas. It's not always clear cut, and it's an evolving process. What I decide one day may be different a week later. So, so there weren't any questions in chat, so we might move across to Genevieve now.
Lovely, thank you very much, Chris. Just checking that my slides are progressing okay.
Perfect.
Yes,
See
we're on
the learning outcome.
Yeah.
Excellent. So thank you, everyone, and it's lovely to be here. I'll just get whoever is not on mute to mute themselves because there's a lot of background noise. Not sure who that is, but great. Okay, so thank you. It was a very interesting little presentation there, Dimitri, about the feedback that you've got from interviewing those 10 GPs, and some really good gems there, particularly around the negotiation and the communication tips. So for the next hour or so, I'm going to be talking about my take on assessing fitness to drive as a practicing GP. As mentioned by Chris at the beginning, I am one of you. I'm a general practitioner. I used to be in regional Queensland for many years. I then was working in regional New South Wales, and now I'm working in regional Victoria. So I've worked my way south. I'm now in Ballarat, and I just want to acknowledge the Dja Dja Wurrung and the Wurrung people of the Kulin Nation, the traditional owners of the land in which I'm speaking tonight. So why are we doing why is assessing fitness to drive so challenging? As was mentioned by Dimitri earlier, driving is a really complex instrumental activity of daily living. So it requires a number of different sensory, motor and cognitive skills. And you need not only for each body system to be functioning properly, but actually for them to be coordinated together so they can interact with both the vehicle and the external environment at the same time. So you need good vision, you need good visuospatial perception, hearing, adequate cognitive function, particularly attention, concentration, and those higher level functional planning and spatial awareness, as well as judgment, decision making, reaction times, etc. And as well, you need adequate motor function as far as power and coordination goes. So it requires a number of different body systems to be working, and that's really hard to judge. As mentioned by Dimitri, it is hard to judge this within the context of a consultation room, and hopefully through publications like the Decision Aid and also some of the things we'll be discussing tonight, will give you some of those tools to try and help negotiate this very tricky area. So we have both moral and legal responsibilities when it comes to assessing fitness to drive. And I think that an overall principle to remember is that driving is a privilege. It's not a right. And we really have to try and juggle the well-being of individuals and their, as was mentioned by Dimitri, the lack of independence or the reduction of socialisation, etc., with the needs of society and the safety of our roads and those on it. Okay, so let's start with a little bit of a case. So I've got a few polls that are going to be doing tonight. So that's just to keep you all awake and also to get a bit of an appreciation of the thoughts within the group. Now, these polls are anonymous, so feel free, please just to jump in, say your bit, and it'll be interesting to see what the thoughts are. So let's talk about Larry. So Larry is 76. It's a Monday afternoon. He's a long-term patient of the practice. Been there for 20 years, but you haven't met him before. His usual doctor isn't working till Wednesday and doesn't have any free spots until Friday. But Larry comes in and says, look, can you please fill out this medical report for renewal? Also got some scripts done. We want to talk about medication side effect and also, yeah, I'm just worried about the COVID vaccination booster. So can you talk about that as well? You booked 15 minutes, but you happen to have a gap afterwards, so you're not particularly pressed for time. So people can kind of get that thought about Larry sitting in front of you in your room. So this is the poll we're going to do. Now the poll, have a bit of a read now, decide which one you want to do, and then we'll launch the poll, which doesn't have enough room, unfortunately, for all of those words. So how do you approach Larry's request? Are you going to ask him to come back to get his one with his regular doctor on Friday and just talk about his other concerns today? Are you going to complete the medical certification after you do a chart review and physical examination? Are you going to draft the certification but then leave the sign off to his regular doctor? Or are you going to do some examinations and talk some questions but not actually do the form and ask him to come back on Friday for his regular doctor? So slightly complicated. Now you may do something different, but pick the one that's closest to what you would do in this situation with Larry. So I'm going to launch the poll now, and if you can just answer that as quickly as possible so we can get through a time, that will be excellent. All right, so hopefully that's launched now. Lovely, so you just give it a few extra seconds. Thanks for answering so quickly, everyone. That's great. Okay, I'm just going to close the poll now and share the results. So we have 48% who are going to asked him to come back to get his driver's license with his regular doctor on Friday. And we've got the next 25% will draft it and then sign up to complete the regular GP. And only 15% are happy to complete the form today. Thanks, everyone. All right, so now just go back to screen sharing. Can you see my screen again now, or is that have a look here?
Yep, we're back on the
Okay.
PowerPoint.
Back on PowerPoint, lovely. Okay, so we'll come back to Larry in a minute, but let's talk about the Assessing Fitness to Drive guidelines. So as mentioned, we do have 2016 ones which are currently valid. Now, use of these guidelines are not only important for sort of road safety aspects, but also will help your own medical legal exposure in the event that there is a crash or someone disputes a licensing decision. So it's not just important for your being a good doctor and being a good citizen, but also for medical legal reasons. Now, you do one every 5 years, so there was one due in 2021. During the drafting process of the new guidelines, there was a little thing called COVID, which ended up delaying them somewhat. So there is a 2022, they've now put a 2022 edition, and this has got an extra 49 pages, so it's now 237 pages instead of 188. There's a new section on medicinal cannabis use and driving, and so essentially it's against the law for people to drive with any amount of THC in their bodily fluids. But the cannabis oil, the CBD, is not subject to the control. So there's quite a bit of information there, as well as updates on all of the other sections and some expansions. So as far as when they're going to be done, at the moment they are in the process of getting approved to the various ministers, transport ministers around the country. They're due for publication this month, but I haven't yet seen when they're actually going to be published. I'm not quite sure, whether that's going to be in the next month or two, or whether it'll be delayed to later in the year. But they are expected to come out very soon. I have been involved with these guidelines, so I've been a part of the expert panel for the drafting on them, and also with the sign-off, which I did a few months ago now. And as far as part of the endorsing panel for the RACGP, looking at them from a GP's perspective. So they're very similar to previous guidelines. Most things haven't changed, but there have been some expansion and clarification. So once they come into force, they are national guidelines. There are state-based licensing rules, but the guidelines in which those state-based licensing is done are national guidelines. So what is the role of us as GPs in a licensing decision, or any medical doctor that is? So this table's a little bit small. It's just taken directly from the medical, Assessing Fitness to Drive guidelines, so you can have a look at it in detail there. But I put it in just to sort of remind us about what our role is and what it isn't. So when we're looking at temporary conditions, we need to advise people about any driving recommendations or restrictions. We, in the general rule, do not need to inform the licensing body of temporary conditions unless it's going to be something that they need their license taken off them for a significant period of time, or if you're concerned they're not going to fulfill the requirements of that temporary condition. So things like seizures and that kind of stuff, they should be reported. But if you're looking at things like they're having an anaesthetic, or they're starting a new medication or something like that, there's no need to report, but you absolutely have to talk to the patient and document that you've talked about driving with those patients. For longer term conditions, you then have to assess against the guidelines. If they meet for an unconditional unconditional license, that's fine. If they don't, you need to think about whether they meet a conditional for a conditional license, or if they don't, or if you're not sure. Now, a lot of the talk we're going to be doing today is about the not sure aspect. And so often as GPs, we think we have to know whether someone is fit or unfit, but that's not really our role. Our role is to say, do they clearly meet the guidelines? Do they clearly not meet the guidelines? Or do we need further information? And so our role, particularly in those with cognitive impairment or those with frail aged, often we are in the not sure category, and it's about appropriate triage and appropriate referral on, whether it be to occupational therapists, whether for an on-road driving assessment, whether it be to the transport department for other testing, or whether it be for specialist input. So just to remind us to really emphasise the fact that our role is to triage these and to have some tools that can help us guide in that process. Now, just to remind everyone about the online process of in New South Wales. So it is now moved online, which is fantastic. So you don't actually need, there's online, it's all done online now, and if you haven't got it in your medical software, you can go directly online on the web. You can draft, save things. You don't have to finish the form on the day, and you get real-time confirmation of the submission of that driving license. Now, if you haven't used it before, there are some good little training guidelines of how to do that. So this is a sample screenshot from that. You'll find that if people have had previous conditions which have been notified, they will automatically pre-fill on the form, which is really great, and you can just add any or make any variations depending on what the conditions of the patient are. Now, the recommendation section is really important, and so this is about whether or not they meet the criteria or don't meet the criteria. Now, just to say, if someone is older and they have to have medical certification every year after they're 75, for example, that doesn't mean that they may still be fit to hold an unconditional license. They'll still just need annual review. So it's about whether or not, as per the guidelines, they meet, and not just related to age, but what they actually meet for a conditional license versus an unconditional license. And that's fairly straightforward in most cases by looking at the relevant guidelines for the conditions. As far as the other sort of recommendations go, there are ways of giving someone a license that is restricted, and it might be around how much, whether they drive in daytime hours only, whether they go in a particular radius, or other such restrictions. Now, there's some controversy around this. I did some work with the RACP, as in the College of Physicians, around, they did some assessing fitness to drive work with them, and talking to some geriatricians. I'm interested to hear what Kate says later, but there is some controversy about whether or not these are a good thing or not. It has been shown that people that are older are much more likely to have accidents closer to their home, and that's probably because a lot don't drive a lot out of their home environment. And those with cognitive impairment, although they're more familiar with the roads around them, if something changes, like a child runs out in front of a car or in certain weather, etc., that can be sometimes difficult for their reaction time to be able to be coping with that. So the general consensus is that restrictions sometimes can help in the transition to not driving, but they shouldn't be used for someone that really shouldn't be driving anyway. So it's not like, oh, we'll just keep them for 10 kilometres around their house and that will be okay. If they're not fit to drive, they're not fit to drive. But you can sometimes use restrictions as part of that transition into a non-driving set. So I think it's something to do with clear consideration. Things like daylight hours only are really only useful if someone has visual problems or other sort of reasons why their reactions and things are not going to be as good in the evening. So particularly those that have issues, macular degeneration or other sort of issues that like the limiting night driving might be useful. Okay, so drivers over 85 in New South Wales, so they have a choice of taking out a modified licence or keeping an unrestricted licence. And if they have an unrestricted licence, they need a practical driving assessment every 2 years. The modified licence does limit, in general, how far they can go around their home, etc. Now, once again, this is very useful if someone is fit to drive, but they don't want to have a practical driving test. A modified license is fine, but just again, be very careful if someone is not able to pass a driving license or practical driving assessment, or they're worried they won't be able to, they maybe shouldn't be driving at all. So just keep that in the back of your mind. Okay, so when we're thinking about driving, it's not just when someone comes and presents a form for us. And this is a really important point to take, and not just about the elderly, but all of our patients. When someone is diagnosed with a condition which has driving restrictions or recommendations, it's very important that we mention it as we are diagnosing, assessing, and treating these conditions. So we're pretty good at remembering these kind of things when you have someone, for example, it's coming with seizures, but not always when people are having issues like sometimes sleep disorders or psychiatric disorders or substance abuse. So we just have to remember that, just be familiar with the various conditions which are mentioned in assessing fitness to drive, and just remember that we do need to look those up and talk about driving in those when those issues arise in consultations unrelated to driving per se. We also got to remember about temporary conditions and giving people advice. So for example, if you start them on a medication which might cause drowsiness, to give them advice about not driving until they are established on that medication and established they're not going to be impaired, for example. There's a bit of a list there of temporary conditions. I want to emphasise that that doesn't mean you have to talk to the driving traffic authority about these. It's more about mentioning it, the restrictions or recommendations, and documenting it in their charts. So the one on the bottom there, deep vein thrombosis and pulmonary embolus. Now, I'm just wondering how many of you are aware that in the current guidelines, and this will also be in the 2022 guidelines, about the recommendations when it comes to DVT and PE. So the recommendations are they should be advised not to drive for at least 2 weeks following a DVT and for at least 6 weeks following a PE. Now, I want to just stop for a second and just mention that there are really two kinds of recommendations in the assessing fitness to drive guidelines. You first of all have those that I like to call the thou shalt not, the absolute you can't drive if you have this. So if you have, for example, unexplained seizures, you just are not allowed to drive. You know, do not pass go, do not collect $200 type thing. And then you have the recommendations, where it's not illegal to drive with this, but these are suggestions or recommendations you should make. Now, with these recommendations, it's important that we are aware of them and that we document them in the chart after having discussed with patients. And so the DVT 1 and PE is a little bit controversial because there's not a lot of evidence that such an event is unlikely to develop an acute PE and cause a crash. So there's no licensing standard, there's no thou shalt not part of this, but this is an advised non-driving period. So having given that preamble, we're going to go to our next poll, and that's going to just ask you which best describes you. Have you never specifically discussed driving recommendations in a patient you've diagnosed or are treating for DVT or PE? Have you sometimes discussed them? Do you routinely discuss them, but sort of in general terms? or do you routinely discuss them as per the guidelines? So that's 2-week and 6-week guidelines, or have you not treated a patient with DBT or PE? So I'm going to launch that poll, and it'll be interesting to see the group. And don't be embarrassed by it. Most people haven't really discussed it. So if you're sitting if you're sitting there, don't worry too much. But let's see what the group are thinking. Okay, that's great. I'm just going to give you another couple of seconds. Okay, so as suspected, and this is actually very similar to when I've done this, asked this poll of other groups, 2/3 of the group have not discussed driving recommendations in a patient with DBT and PE, and only 5% have routinely discussed it as per the guidelines. So that's pretty common. And we're going to just go to the next poll, which is going to ask you, after in the future, do you plan to specifically discuss driving recommendations with someone with DBT or PE? So I'm going to launch that poll there. Excellent. All right. So a bit of a loaded question. So hoping you will have something. And 93% said yes, which is fantastic. Okay. So that's a little bit of a learning or a change of practice, hopefully, that you have got from watching this webinar. So I just want to emphasize again, these aren't recommendations. This is not saying they can't drive. This is what the recommendations are. And it's going to help protect you medico-legally. I have a strong interest in medico-legal matters. I'm a board director of MDA National, and I have worked in medico-legal education for many years. And so, as well as my general practice interest, I'm always thinking, how can you protect ourselves in the event of a patient complaint or litigation? And so when there are recommendations made by assessing fitness to drive guidelines, it's a good idea to be aware of them and just mention that to the patient. And then it's up to them about what they want to do with it. Okay, so let's go back to Larry. So if you remember, he presented with a medical report with his driver's license renewal. And you can have a look through his previous notes, and you note that a month ago, his usual GP noted, his wife is concerned about memory loss. We have to review next visit.
Genevieve, we're just still on the poll.
Okay, I thank you for letting me know that. Let me see if I can hide that. Okay, back now to the slide.
Yep, perfect. Yep.
Thanks very much, Chris. So, back to Larry. So you noticed his wife is concerned about memory loss. So this is something you might think, okay, maybe Larry has had a chat to his doctor about driving and is coming to see you because you hope you don't know about that, or it might be completely innocent. As Dementia mentioned in her study at the beginning, this is the doctor shopping around for medical reports for driving is really common, particularly for commercial drivers, but certainly does happen with older people as well. And very commonly, you have a patient you've known for a long time, they know the doctor, and they say, oh, we'll do it today, Larry, but next year we'll have to really rethink about it, or some comment to that degree. And then quite often, that they will present to another doctor hoping that they will retain their license. So that's not uncommon. So if you do have that new patient or a new patient to you, it's always a good idea to just to have that in the back of the mind. And it's not saying don't do the medical examinations for them, not at all, but just to have that thinking maybe this is something that they are that their regular doctor has raised with them, and they're trying to not go down that route, so asking for second information. I'm actually surprised. I'll just have a little personal anecdote. So my parents live in Canada, although they're coming back to Australia soon. They're in their late 70s. And when my dad went to he came back to Australia and wanted to get an Australian license for a while, he had to rock up at a GP. He doesn't actually have a general practitioner, is not on any medications. He was 75 years old, and the doctor was like, sure, here, I'll sign the form, and asked him very little questions, didn't even examine him. And I was just really quite horrified, to be honest, that my dad got a license so easily. Mind you, I thought he was fit to drive at that age. He's now stopped driving, but at that age, I thought he was perfectly fit to drive. But the fact that he wasn't even after examined, and there was no suspicion made the fact that this was a 75-year-old that said he had no medical conditions, he had no medications and had no GP, I thought was a little bit poor. So please just keep that in mind if you're seeing someone. Rightio. So let's talk about collateral information. This was mentioned by Dementia as one of the comments in the studies that her student did. So I'm just going to see what you think is somewhat predictive of driving fitness in an elderly person. And we talked about someone who's got memory problems, so someone with mild or moderate memory impairment or cognitive impairment. So this is the final poll. Let's see what people think. So let me just get to that last poll. Sorry, just gonna try and find the final poll. For some reason, there we go, hang on a second. Here we go. Okay.
I think we've gone, yeah, we've gone to a different poll now. Yep. That's good.
Okay. Great. So when I share these results, we have the majority of people thinking that both a family member reporting they're safe and a family member reporting concern are both helpful. Some that thinks of neither, and a large number think it's just if they express concern. Excellent. Okay. So what they've actually found with research is that if a family member expresses concern, that is absolutely really important and is somewhat predictive of their of impairment. However, the family member who expresses that they are capable or safe is not very predictive. So essentially, trust them if they're saying that I think this person's not safe to drive, but don't necessarily trust the fact that they are capable or safe. And there are a couple of reasons for it. It may be that a spouse, there are sort of reasons why that they would like their partner or someone to keep driving. So there might be some secondary gain issues. They also just might not be aware if that's someone about the safety, and they might get very used to how they drive, etc., and they may have impairment themselves. So essentially, the concern is something to pay attention to. Right. So let's talk a little bit about driving and dementia, and how we can triage this in a general practice setting. So we'll talk first about those with physical frailty, which is a little bit simpler than those with cognitive issues. So there aren't any strict cutoffs, but there are some sort of instruments that can help us thinking about the triage. So there's the 5 times sit to stand test, which is basically when they sit and they so basically they go from a sitting position and then sit up and down 5 times as quickly as possible without pushing off, so without actually using their hands to push off. If they can sit and go up, and if they can do that in, it takes them, should be less than 10 seconds. That can be quite a reliable thing, saying they have enough physical strength and coordination for driving. And the timed up and go test is essentially when someone has to jump up after the command go and walk a distance of 3 meters at a normal pace, turn around, walk back to the chair and sit down again. They can use things like canes or assistive devices. But if they're more than 10 seconds for the 5 times sit and stand, or more than 9 seconds for the up and go, that's sort of fairly good for prediction of disability, which may or may not result in enough impairment to be able to drive. But those are sort of some good tests for frailty. There's also a frail scale risk assessment. So someone's got their is unmuted. Maybe you, Chris, maybe you can unmute yourself. There's just a bit of background noise.
No, not at my end. I'll just have a look. I can't see anyone unmuted at the moment.
Okay. All right, that's right. Maybe that's just maybe this is me. So that's a couple of little helpful tips that can be done to help assess physical frailty. And as I said, the Sydney North PHN has got a frail scale risk assessment as well, which is quite helpful. So that's the physical side. Let's talk about the cognitive impairment. So there are some general principles that have been established for about the last 10 years or so. So there are those with dementia have a significantly higher risk of car accidents compared with age-matched cognitive normal drivers, and odds ratio of like 7.9 to 10.7. So really about a 10 times the risk if you have some cognitive impairment compared with if you don't. Certain forms of dementia are associated with worse outcomes, so particularly those that have prominent frontal lobe and executive dysfunction. So those with primary frontotemporal dementia, the frontal variant of Alzheimer's, and some forms of vascular dementia have a worse outcome, particularly when they've got impairment in planning, organisation, problem-solving, judgment, insight, and impulse control. Okay, so some of the principles. Those with mild dementia may be safe to drive, but can't hold an unconditional licence. If you're looking at the MMSE, which is a classic screening tool we use, it's not that as a total is not particularly predictive for driving risk. So it's not good enough as a screening tool for that. The co-pilot, which is when someone's with them, and so doing this sort of helping them navigate, etc., is not considered a safe or recommended approach for those that are unable to, not safe to do it themselves. The gold testing is, of course, OT on-road testing, which is both expensive and sometimes difficult to get hold of, but that is your gold standard. The other thing is that the review should be 6 monthly for those with dementia. Now, the assessing fitness to drive talks about cognitive impairment, and it says at least annual review. But when you look at the geriatric medicine statements and things, they really say it probably should be 6 monthly. That will depend a little bit on the stability of their cognitive function. But I've done a lot of reading on this, and I think that 6 monthly is a much safer for all involved to do. So if someone does have a conditional license, when you put the recommendations, if you then say 6 monthly review, that will help determine about try and pick people up before they become more unwell. Okay, so some other principles. So when you're looking at when they've looked at increased risk of unsafe driving. So if a carer's rating is that their ability is marginal or unsafe, if they have a history of traffic offences or crashes. Interestingly, if they reduced their driving mileage or they have self-reported situational avoidance, that also can increase your risk of unsafe driving. It might be because they're driving less because they don't feel safe, or also might be they're out of practice. So the patient that says, oh, I only drive, I just want my license in case I need to. I really only drive a couple of times a year. You know, my husband/wife does most of the driving. It's a bit of a red flag, because if they're not driving regularly, they're getting out of practice. The way that I like to think about this is if you have for example, a surgeon that decides they've sort of cut down. They're not doing all the major abdominal surgery anymore. They're just doing this. They're doing the odd appendix. So maybe just do a couple of a year. If they then do their appendix, they're not going to be as skilled at doing it. They're going to be de-skilled with that. And if something goes wrong, and for example, they nick some bowel, and they have to then the procedure becomes complicated, they're much less likely to be able to react properly. So just like an older doctor who is cutting down their types of procedures, the same principles involved with someone that's cutting down their driving. This is where I should say that's where there's more the complexities happen when you're looking at restricting as far as their distance of driving. So the whole restricting someone's amount they're driving can also lead to de-skilling. So that's the sort of thing you have to weigh up. Those that have aggressive or impulsive personalities are more likely to be unsafe, and the self-assessment is not helpful. So it's a bit. It actually goes both ways. If someone feels they're not safe, sometimes they're actually okay. But particularly if they feel they're safe, that they are definitely not guaranteed to be safe. I would say, however, if someone doesn't feel confident in driving, it's best if they don't drive, because that confidence, without that confidence, they can then make errors based on that sort of anxiety, etc. So there's been some studies around this. This was Australian research back from 2013, and basically saying that they did a whole range of assessments in older drivers, and they basically said that they found that that how people rated themselves as drivers and how they actually performed as drivers weren't very well correlated, particularly in those that have any kind of cognitive impairment. Now, as far as how to actually use this practically, there's been some great research from Canada that was published in 2017 and then 18, and that was from a primary care accredited memory clinic. So what they were looking at doing is trying to work out what tools can we use in a primary care setting that will help us triage who is likely to be safe and unsafe. And they've come up with a checklist for driving safely in dementia. So first of all, they look at history of accidents or near accidents or family member concerns. They then have some cognitive testing, and we're going to talk about those, some of those in a minute. The main emphasis, as I mentioned earlier, MMSE in isolation is not all that helpful, but the copying intersecting pentagons and also the clock drawing test, those particular aspects have been found to be a correlation with the cognitive ability with driving, and also trial making A and B, and we're going to talk about those next slide. Cognitive test scores are possibly helpful, so that's the more neurocognitive testing that is done in sort of more formal settings by neuropsychologists or by geriatricians. They're possibly helpful, and just the general level of dementia severity. So if someone is unable to perform 2 instrumental activities of daily living, bathing, feeding, etc., or instrumental dailies of daily living, so more sort of complicated things, and basic activities of daily living such as feeding or dressing or bathing, that is an indication they may not be able to drive. So when we go on to trial making A and B, so these are a bit like a dot-to-dot puzzle that you have for children, but they don't make nice little pictures. So essentially the trial making A is you start at number 1, and then you time them about how long it takes them to draw between the dots. So 1, 2, 3, 4, 5. So I have to find the appropriate number and draw a line connecting those. So if you are unable to complete that in 48 seconds, it suggests that you may need further evaluation. So this is just a screening tool that is quite useful to say, look, I think we need to look at this further. Trial making B is similar but a bit harder. So it alternates between letters and numbers. So you go 1A, 2B, 3C, 4D, etc. And the cutoffs for this test is that they need to do it in 3 minutes. Do it in 3 minutes or less, or have three errors or less. So it's a 3 or 3 rule. So if they more than 3 minutes or more than 3 errors, they fail that test. Now, what they found in these when they instituted that test A and B is that most people could do A okay, but they found B quite difficult, and so some people weren't able to complete that at all. And if people weren't able to complete it at all, assuming appropriate literacy levels, so that is important to take into consideration. That may be again a sign that driving may not be safe for them. So what they actually did is they have done a couple of studies around this. So what they did is they made people do the tests, and then they put everyone on road testing, and then they correlated the results of those, and they found there was fairly good correlation with those tests made. Now, this is not something that you should do in isolation. So when we go back to our checklist, some people will do quite well on cognitive tests, but have other concerns like family member concerns. Some people the opposite. They seem to be doing quite well as far as their history and their family member, but they do quite poorly in the cognitive testing. So none of this should be taken in isolation. These are just helpful tests and things that you can look at that can then make you fairly confident that someone is going to be safe to drive. I'm fairly confident they're not going to be safe to drive, or in that middle, they're saying, I'm just not sure, and we need to send you on for further testing. So what happens if someone is clearly unfit but won't stop driving? There is those sort of negotiation, that communication tips that Dimity talked about earlier, and having those conversations, talking about driving being a privilege, talking about the safety of other people in the community, and trying to look at ways of maximising people's independence are all really important. There are some medico-legal implications as well. So one of the nice things about being online with the assessing fitness to drive forms is if someone's unfit, it will automatically go back to the RTA if you complete the form, and if they don't have a form, but you are concerned about their driving, if you do inform the Road Traffic Authority, you are protected from civil and criminal liability, even though even if the patient says that you can't, I don't want you to report, etc. And so even if any times you report someone's driving fitness, again, you are protected medically, but the recommendations are if someone is not able to appreciate the impact of their condition, if they're not going to take notice due to cognitive impairment, or if they are driving despite your advice and is likely to endanger the public, it is recommended that you do inform the RTA. In some states, particularly South Australia and Northern Territory, but particularly in South Australia, it is actually mandatory to report people that are not fit to drive. So you get in trouble if you don't report. But in other states and territories, it is recommended they do, but ultimately it is the responsibility of the patient to inform the RTA if they are unfit. But you can override them if you don't feel they've done that appropriately. Okay, so we've talked about this a bit already. And I just want to say it's all well and good having the guidelines and having implications, but these are difficult conversations and they're not always clear cut. I do like the kind of suggestions that were brought up by Dimity's GPs earlier, saying things like there's sort of that negotiation around, I just don't, I can't be confident that you're fit to drive, but we will, if you want to keep your license, you'll just need to do an on-road assessment. Just to let you know, people do actually need a driving have a driving medical certificate to cover them for on-road assessment. So, but you can make a recommendation that the driving license medical certification is just for testing. It doesn't have to be sort of an ongoing driving license medical. So if you're really unsure or if you someone is unfit but they want to prove that they're not, using those kind of strategies is helpful. And just to remember about this impact of losing licenses should not be about giving someone a license, a medical clearance for license if they're not fit to drive. But it is important to consider these, to bring them up and to try and minimise the impacts as much as possible when you're looking at things like alternative driving arrangements, etc. So the last part of the talk I want to do is talk a little bit about why I am so passionate about this topic and have been for the last several years now, and why I've sort of got involved in some of the driver's license panels and the assessing fitness to drive guidelines. And it all started when I made a YouTube clip in 2015. So I'm not going to play the clip, but I'm going to go through some of the slides on the clip and sort of talk through my experiences in this. So this is the clip that I did called "Don't Just Sign on the Dotted Line." And it starts by, I have a vivid and shameful memory when I was bullied in my first term as a GP registrar. I had an 88-year-old feisty patient, and I vividly remember when she hobbled into my room using her wheelie walker, had a long list of medical conditions, and had this driver's license medical form sort of shaking in her hand, and essentially she was quite obvious that she really was not fit to drive, but she had a cane. She essentially bullied me into signing the form, and very much using, she was living outside town and she wouldn't be able to get to town otherwise, and using all her manipulation as much as possible. And I signed the form against my better judgment, and then about a couple of weeks later, I heard that she died behind the wheel, and I just absolutely panicked, and I just imagined this horrific multi-vehicle accident, and that I was going to be hauled in front of a coroner, and I was just absolutely petrified. What actually happened was she executed a perfect reversed park in town, and then had a CVA directly in the car before she got out. So she had a massive stroke and died behind the wheel, literally while she was parked. So since that time, I have never again gone directly against my clinical judgment when signing a driver's license medical. But as the years went by, I wasn't really as diligent as I probably could have been. I didn't routinely seek collateral history. I didn't send many drivers for practical assessments. I sort of went a lot on gut feel. And I know it was important, but it wasn't something I was particularly passionate about. But it all changed on the 15th of July in 2015. So this was the morning after my partner's 39th birthday, and he was an emergency physician staying with friends in Los Angeles. Went for his usual morning jog, and when he was crossing legally on an intersection on the green walk sign, he was hit by an elderly driver. The driver had run a red light, said that he didn't see it, and then he confused the accelerator with the brake pedal and plowed straight into him. My partner died from his injuries within an hour of reaching hospital. He was due to come back to Australia a week later, but instead only his ashes came. I was in my second trimester of pregnancy at the time. and our daughter never got to meet her father. And tragically, she died a day after she was born. She was born premature, and I lost them both only months apart, and it nearly broke me. I was informed that the elderly driver's family had been concerned for his driving for some time and had urged him to stop. But despite this, his GP, his doctor, had certified him fit to drive only 3 weeks before the accident. So I started looking into this, and I found that just in California alone, where my partner was killed, 700 pedestrians are killed by motor vehicles every year, about 2 a day. And if you look worldwide, these figures are more like 270,000 pedestrians killed per year, according to the World Health Organization. Now, there are a multitude of potential factors involved in pedestrian fatalities, and unfit drivers are only one of the many. But this is one that we can do something about. And also acknowledging it's not just pedestrians that die from unfit drivers. In fact, the people that are most affected by unfit drivers are the unfit drivers themselves. They're more likely to hurt themselves, their family members, and other drivers as well. So I felt compelled to raise awareness of this, and so I took to social media about this. I did this YouTube clip, which is a Pecha Kucha, and that's a Japanese concept. It's 6 minutes, 40 seconds talk with 20 slides, each lasting 20 seconds. It was aimed at other doctors particularly, but hopefully also was of interest to other people. And it was featured on various blogs in the US, the UK, and also on the official Japanese Pecha Kucha site also. It's been shown in educational sessions sort of around country, and I've sort of spoken about it in various settings, including today. So look, nothing can bring the love of my life back, but if sharing my story can indirectly result in one fewer person being injured by an unfit driver, at least some good has come out of most senseless tragedy. And for me, it's really helped me with my grief also. Viktor Frankl, who, as many of you would be aware, is an Austrian neurologist and psychiatrist who survived the Holocaust. He really espoused the importance of finding meaning in terrible circumstances. And one quote which always reminds me, he said, in some ways, suffering ceases to be suffering at the moment it finds meaning. So much of the healing that's happened to me in the last 7 years has been trying to make a positive difference in the world by talking about a topic which is very important but often underappreciated and so difficult for us as GPs. So that I hope that this talk today will help you, as well as learning some tools and some stuff. I hope also that story will make you more strongly resist the urge just to sign on that dotted line, even if you haven't. I rate Betsy yelling at you to do so. And just to remember that driving is a privilege, not a right, and that we are gatekeepers. And a quote I like, which is relevant to this as well as many of the other things we do in general practice, is if all of your patients are totally happy with you all of the time, you are not a very good doctor. So that's the end of the formal presentation, and I'd like now to hand over to Chris and do the last bit of the panel session where we can talk about your questions and comments.
Fantastic, and thank you, Genevieve, for sharing that, your personal story. And I mean, every time I hear your story, it just really outlines how important a role we as GPs plays, you know, in terms of all the things we do, but in particular driving medicals. And yeah, so thank you very much for sharing that. So I haven't had a lot of questions in chat yet, so I can sort of start. If I was going to bring Dimity and Kate on as well. And so if anyone wants to start thinking about a question, sending it through chat, I've got heaps of questions, so I'm happy to start. I thought I'd direct firstly to Kate, just around, because we mentioned earlier on this idea of the radius, and so from a geriatrician's point of view, that giving a radius of driving, what your thoughts were around that, Kate.
Yeah, so I think both Dimity and Genevieve had touched on that one as being possibly that transition. I agree totally with what was said, that you have to be confident that the person is safe to drive. It's not okay just to give someone who you're worried about a restriction. But it is a good starting point to transition someone off. So often it's a discussion I'll have at that initial diagnosis point of someone with dementia, where I'm quite confident that they're capable of driving at the moment. You know, they've got mild amnestic problems and they're performing well on all of those tests that Genevieve spoke about, which is so important, the sort of executive function. But I'll even say to them at that consult, you know, there will be a time, and what we want to do is keep you driving for as long as it's safe. And obviously it's better if you're driving you're much less likely for something to go wrong if you're driving in a familiar place. So often having that discussion that the reason you're restricting them is because you want them to remain safe, because even if they had an accident that wasn't their fault, you know, that has implications on them not driving in the future. So often I introduce restrictions where I'm quite confident that they're safe, but I think it just enters that discussion of raising that driving is a privilege, not a right. So I do restrict people usually sooner than other people might, I guess, but I think it's not an acceptable thing to do if you think someone's not fit to drive.
And really great points there, Kate. And Dimity or Genevieve, any points to add to that, or? That's right. Yeah, and I think there were some really great tests shared there. So amongst talking about the MSE, the trail making quiz, the clock drawing. I know as a GP, I try to do an MMSE every time I do a RTA medical of my elderly patients, but they all complain to me because no one else does it, and why do you always have to do it, Chris? So, and it's interesting to hear there's no, and I've heard this from Dimity previously around using MMSE as a screening tool. So I wondered if there was any comments around that from Dimity. You know, when we're talking about our average elderly patient who doesn't have a diagnosis of dementia, but we're asked a specific question that says, does this person have cognitive impairment? Is there an objective test we should be doing for all our elderly patients in that respect? And you're on mute, Dimity.
Thank you. That's
there we
good. Go. Okay, so I agree with Genevieve. I mean, Genevieve's done her homework. I've seen the geriatricians because I do a lot of stuff around dementia, talking about the trail making tests and clock drawings and so on. You know, another issue about it is that often in general practice, the MMSE or whatever is done by the nurse as part of the 75+ health assessment. And we did a research project about 5 years ago with general practice nurses, and many of them haven't actually been trained in how to administer any sort of cognitive function test. And I know our GP nurse doesn't like people to fail, so she lets them have a few goes sometimes, and that's actually that's they're not an MMSE. And sadly, someone that I had refused to sign off went to the GP up the corridor, and because she'd scored 30 out of 30 on the MMSE, done by our practice nurse who didn't like her to fail, and she said I gave her about 3 goes, and I took the best, you know, which was 30, you know, and she'd practiced it a few times that night too, and so on. So he signed her off, and she did in fact drive into a tree about 6 months later and ended up in hospital, in rehab, in nursing home, and then passed away. So she didn't hurt anyone else, but it wasn't in her best interests to just rely on that one MMSE result when he didn't know her either. Although he had my notes. Yeah. So it's tricky, very tricky.
I think Dimity made a good point, and as I mentioned earlier, people that normally hurt are usually the people themselves that are driving and have accidents. So as far as your opinion, Chris, I think the 3 set of tests that I think are most useful in driving. MMSE has absolutely its uses when administered correctly, but for driving fitness, the clock drawing test, the intersecting pentagons, and the trial A or trial B are really the ones that are going to be the best bang for buck and able to administer fairly easily in a general practice setting.
Yeah, can I add to that? So
Yeah, definitely.
I incorporate a lot of what you've done there too. So the Montreal Cognitive Assessment, I'm not sure if that's a tool used in general practice at all, but it does incorporate a very small Trails B, a shortened one that's not timed, a cube drawing and a clock. And it counts for the first 5 of the 30 marks of the Montreal Cognitive Assessment. So I'll often start with that. And I think in a GP setting, those 3 things you probably can do quite quickly. Then more comprehensive Trails A and B after that. I like that because it gives a timed measure that then when you reassess in 6 months' time, you might not have changed any marks on the 5-point test, but you can almost certainly see that there's an increase in the time it takes someone. So then you can point out to the patient, well, that's interesting, you know, you were able to do this test in, 25 seconds last time, and we can see that, today took you 33, and that's just showing that the speed of thinking's changing and that has impacts on your driving. So I think if you can have those conversations early and show people that there are changes, sometimes they're a bit more insightful, but often, as a good point that Genevieve and Dimity made earlier, it's the people with the no insight, the no judgment, the very resistive ones, and that's where you just have to make that decision that that patient's going to hate you, but you're doing the right thing by cancelling their license. And in saying that, I think it's very important that GPs preserve their relationships with their patients. So I think it's very appropriate that if you think someone shouldn't be driving, but you want someone else to say it, then just let the local geriatrician know and see if they can, because I certainly would take relatives' criticisms of someone driving very seriously, and if a GP feels someone shouldn't be driving, then without a doubt I'm not going to disagree with that at all. So yeah, I think preserving your relationship with the patient is important, and if you feel you're being bullied and you want someone else to step in and do that, by all means talk to your local geriatrician.
That's fantastic, and I think there's always that sort of question of at what stage should I refer to the geriatrician around this. So it's great to know that there's that help there, and I think with the trail making, because I know on a practical note, certainly when I get to trail making B, it may be the way that I'm describing the test, but gosh, my patients have trouble figuring out the 1A, 2B, 3C. It's quite a tricky test I find for my elderly patients. So I've sort of kept it for patients who I'm a bit more concerned about, and but even then, like I think Genevieve said, it's one tool in your toolkit. You don't make a decision based on one test alone. So on a separate note, another question I was thinking along the lines was, it's probably actually directed to Genevieve now, was around that idea of collateral information and what to do when you get unsolicited information. So from family members, whether it's a granddaughter or grandson, child, whoever it might be, says to you, oh, next time you see Nan, can you just take a license off her? I'm really worried about her driving, but don't let her know that I told you about it. How do you deal with that, Genevieve? Because I find it a very tricky area.
That's a great question. So I'll just put my medical legal hat on, and this is there's really quite clear rules when it comes to unsolicited collateral information done without consent. Is that you can't actually use it unless they agree to that you then can disclose that you've heard this from someone. You can't actually use that information. Now, you can, in the back of your head, sort of think, okay, that person's got concerns, but you can't actually document that in that person's chart. This is unless the person has got an enduring power of attorney for health matters, and so there's a different situation if it's a carer in that regard. But if someone is clearly competent as far as their ability to make decisions, then you can't use that collateral information without consent. Now, that's the legal definition. That's a legal side of things, and again, you can't also write that in the person's chart until you've discussed it with the patient themselves. That's just pure legal position. But of course, you'd be back of the head, you'd be very concerned. But I think that there are the two aspects that can happen. First of all, people that are concerned about a relative's driving can report directly to the Road Traffic Authority that they are concerned about someone's driving, and that you can reassure them that won't take someone's license off them. All it will do will then precipitate the Road Traffic Authority to send this person a medical certification medication and say they've got to go to a GP and get assessed. So that's one way can they do it. They can do that anonymously as a concern for someone's driving. But really, I think the conversations have to be about, look, we need to be all in this together. You know, it's really important that if you're concerned, we're much better if we do this and discuss that concerns with the person. So I think that's the emphasis should be on that. But strictly legally, you can't actually use that information.
Which is incredibly tricky, isn't it? Because we sort of live in this situation where we're seeing all different family members at different times, and so basically the approach to the GP is to be very clear to the person giving that information that you won't be able to act on it if they and encourage them to have a meeting with their parent or grandparent. Yes, very tricky situation.
You can use it if they give consent that you raise that with the person. So say, look, you know, your granddaughter came in and they were concerned, and that's when you would put it in the chart. You shouldn't put it in the chart before that time. So and this is where it also becomes tricky about documentation. So people shouldn't have stuff written in their chart they don't know about. So this is not just for driving fitness, but as a general rule for documentation. It does get messy and tricky, but whatever, the main emphasis is to try and make sure that it's all as transparent as possible about who's concerned about what.
Excellent. And I guess along that medical legal aspect, so the other question would be, we talked about notifying. So say if you say to a patient that they're unfit to drive, and then you become aware they're still driving, and that we're protected in terms of notifying the Motor Accident Authority. Should we talk to our MDO first before we do that? Because I guess in effect it may be a breach of confidentiality, but
no need.
No need. Okay.
No,
excellent.
very clear. You can report to if it's with those criteria that I mentioned earlier, that they're driving against advice, or they can't. They don't understand the impact, or they've got cognitive impairment. There is no issue with you reporting at all, and you don't need any kind of medical legal thing. I just want to mention about the collateral, if I just one extra point. I found that actually seeking collateral information actively is really helpful. You do need consent from the patient to do that, but the way that I often will, it's a bit I suppose a little bit tricky, but I sort of sometimes if I just don't really trust what they're telling me, I'll say, look, I just want to talk to your spouse about the driving. If they say no, I say, well, until I get the information, I really can't sign off on this. So if you want me to sign off, I do need to talk to someone. So that sometimes I do use that strategy. And that's only if what is being presented to me doesn't really have that, not really comfortable with their driving ability. I'd rather do that than actually get in the car for myself. Mind you, as mentioned, if they say, oh, they're fine driver, I don't necessarily believe that. But if I have concerns, that again adds weight to the fact that I would need to send them off for further testing.
Excellent. So now we've got a couple of questions coming through now. So the first question is so directed to any of the panel. So if a patient is frail rather than cognitively impaired, are there any other helpful assessment options other than an OT driving assessment that we can utilise? I'm not sure who might want to take that one.
Well, I did mention that, so that sit to stand test, the TUG, also the frailty assessment index. So those will be in the PowerPoint that we presented. But I'm interested if Kate has others that that she uses or recommend.
No, I was going to reference your ones that you mentioned, Genevieve. I thought they were very good ones. Yeah, I guess I don't tend to see the physical ones so much because I think the GPs are very good at picking up those ones. So those ones tend to don't get to me as much as the cognitive ones. But no, I thought your objective assessments were very good. Neck rotation and vision and all those other things I'm sure are probably better done by a GP as well. They're very good at assessing those things. I've only had, to be honest, one person in the whole tenure career that was someone that was asked for the opinion of their physical capability. So the majority of mine are all more cognitive concerns.
Actually, and I was just thinking another good question around this, which often comes up with registrars who are sort of enter general practice and then all of a sudden gets given these forms and just have to fill them out and haven't really been trained in it. A lot of questions I get asked around and I know it says it in the Assessing Fitness to Drive book, but you know, what is a reasonable examination of it? I was just thinking about the neck rotation, but you know, how much examination do you need to do, top to toe, neurological examination, heart sounds, all that sort of stuff. So I'd be interested, yeah, from the group, and I guess this is a bit more broader than a dementia patient or cognitively impaired patient, but maybe Genevieve, yeah, what would you consider the bare minimum for an examination as part of an assessment
Sure.
to drive?
Yeah, good question. So it depends a bit on how well you know the patient. So, and what are their pre-existing conditions. So if it's a new patient, I would say a bit of a top to tail is probably going to be a good idea to do. If it's a well-established patient and you've got a record of their blood pressures and their and other things, I don't think you need to do a very extensive examination if you're confident that they have had their overall assessment. If they're elderly, and I've had the 75-year-old health check often is a good sort of baseline of the kind of examination you want to do for them. If it's not, if it's a commercial driver or otherwise, I think if you it's the same kind of recommendation you're doing an employment physical. So the kind of basics that you would do in an employment physical for someone that's going to the mines or something like that is adequate. I wouldn't necessarily go and do audiometry and all that kind of stuff, but just your sort of basic physical examination, particularly thinking about the skills that are required to drive. So as Kate mentioned, neck rotation, vision, hearing, coordination, strength, the sort of things that you think might be are the most important things to test. Mostly I would just like looking at the general coordination, so looking at coordination tests and strength tests, and looking at sort of reflexes and stuff, I think is reasonable to do.
Well, I just remembered there's one other cognitive kind of test that I do that's quite quick and easy, and it's one called the Luria 3-step motor command, which can be quite an insightful quick test as well, where you just ask the patient to repeat a 3 repeated motor sequence, or you can look at alternating coordination things. So just something like this one's one of them, or the Luria, you get them to do a fist, a palm, or the edge of the hand and a palm, and you show them 3 repeats, and then you ask them to join in and they do it with you, and then you ask them to continue and carry on till you tell them to stop. I think that really picks up those people that have the poor motor planning, the poor concentration, and so it can be really insightful, quick test if everything else is looking okay, but you've still got concerns.
Yeah, fantastic. Now we've got, I know we're finishing in about 3 minutes. We've got 2 more questions. One is around temporary conditions and the other is around OT driving assessments. I might go with the OT driving assessment first. So I guess the theme of these questions is around how do you arrange an OT driving assessment or practical driving test, and this idea of you do it 1 year and they pass, when do you do it again, etc. Those sort of questions. So, and I think, Genevieve, you made a really good point that, and I learned this early on, that you actually have to tick them as fit in order to do the on-road test, which is a bit nerve-wracking when you're like, I don't really want them to be driving. So anyway, yeah, so either Kate or Genevieve or Dimity comment on the OT driving assessments.
Well, I'll leave it up to Kate because my practice is actually in Northern Sydney, so we might use the ride rehab OTs or something like that. But for the Hunter New England people, or certainly the Central Coast, Kate probably knows more than I do.
So my approach, I tend to use them if I'm fairly confident the person is fit to drive, but they're not scoring well on their cognitive testing. I think for other reasons, often it's limited formal education or other reasons. And so my approach often is to reserve it for people who I'm pretty confident will pass, but I need some objective good measure that they will. Because it is an expensive test for some people. But then, Dimity, your study also had some good discussion points that GPs made about talking about costs. And so I think in the scheme of things, it's not a lot of money to pay when you're looking at, the safety of driving and the impact that you not being safe to drive is going to have on other people. So I actually try and minimize the cost in a way and say, well, you're paying insurance for a car and all of those things. Really, the cost of the test, if it's the best test to determine that you're safe to drive, I think it is justified. So if I really do think I need that information to make that decision, are you safe, I try and sell it to them a bit that way. Or that feeling that, you know, if driving is important to you, you know, I do need you to sit this test, otherwise I'm not confident that you're safe. In terms of the time frame of repeating it, often that's where if I've got cognitive assessments at the time I send them for the first assessment, and then at that 6-month and 12-month follow-up, I'm seeing changes. Then it's that time to have that discussion and say, well, yes, you did pass the test then, but, you know, you can look and see that when you drew the cube this time, you missed out one of the lines, or, you know, the numbers on your clock were quite different here than here. So often having that discussion and being able to show them that things are changing with time, you can have that discussion about, well, in actual fact, no, I don't think you should do that test. I think it's time you stopped driving. Yeah, so that you kind of intervene in a way that way rather than repeatedly testing them. I hope that answers that a little bit. Genevieve, did you want to?
That university
very much agree with
is good too. And
yeah.
you can, yeah, for helping people work it through. Yeah.
I very much agree with Kate about the repeat testing idea, is that often they don't need repeat testing. It's that if you've got like their baseline cognitive testing stuff and a significant change in their physical or cognitive abilities would then require a conversation saying, yeah, you're not really safe now, or if they wanted a second test, that'd be that, but not every 12 months or every 2 years. It's really based on their other medical conditions and how they're going. As far as the practicalities of getting the test done, I'm now working about that, so I can't talk for your area, but I think in general, if you talk to the RTA, and they certainly will, some people will be able to do on-road testing directly, but others will need OT, but they can talk about people in your local area. But Chris, you may have some more insight into availability in your area.
Yeah, and I believe it is listed on H&E Health Pathways. So there are some specific providers who do it. So I would go to Health Pathways to check. And obviously for our rural colleagues that are on tonight, it's another challenge of, you know, if you're, you know, well away from Newcastle or one of the other centres, it's just another challenge to decide, do I really need to do this test and can my patient afford it? It's very tricky. But yeah, Health Pathways is really useful. In terms of, so we're at 8 o'clock now. There was one other question around temporary conditions. I think, it's a really important point, and like I was saying before with registrars, it's one thing that when we start, we're not aware of. And so if there are any registrars on tonight, I really encourage you to have a look at the handbook and have a look at those temporary conditions. It's amazing, exactly like Genevieve pointed out, you know, not being aware of DVT-PE, I've certainly learned something tonight. And so the question here was just around, you know, what happens to a person with a CAMS boot on the left leg driving on a manual, and I think that would relate to the temporary condition, I'm assuming, Genevieve. But
yeah, absolutely. So they shouldn't be driving a manual with that CAM boot. So this again, any temporary condition which is going to impair their ability to use pedals or that sort of thing, you should advise them they should not be driving. So they don't have to inform any medical, any sort of the road traffic authority, etc. But you need to think about it. When you've got someone in that situation, mention it and document it.
Excellent. And it's so important that, you know, the documentation, exactly like Genevieve, and having that management framework. I think we all have a framework, but just, you know, as part of, if you go down, you know, what do I need to do? A follow-up, safety netting, driving. Just have driving on your management framework, and you'll remember these things because there's so many things that conditions that this is relevant to. So I think, given the time, it's 8 o'clock. We've had your attentive for the last hour and a half. It's probably time to go spend time with your families. And so I'd really like to thank our panel tonight for spending their time and speaking to us. It's been an excellent talk, and I've certainly learned a number of things tonight that I can take away from my practice. And I'll hand it across to Melissa to tie it all up.
Okay, thank you so much, Chris, and thank you for facilitating tonight. You did an amazing job. We did have apparently some people were having some tech issues with the chat box, so we worked our way around that and had them texting in. But if anyone has any questions that they'd like to forward to education@hneccphn.com.au or to myself, I'll gladly pass those on for you as well if you didn't get a chance to ask those questions now. Thank you for those that did text. We worked our way around that, so that was great. And I really appreciate everyone's time tonight. Such an important topic, and thank you to the presenters for being here. The kit that we did discuss, Timothe's just popped that in the chat box as well. That will be available after March 30th, and that will be along with the presentation and a copy of recording of this presentation as well, available in our education library. So if anyone has any further questions, give me a call afterwards or drop me an email, and I'll follow those up for you. Thank you everyone for being here tonight. It was a great informative session, and really important. So thank you all, and good night.
Thanks, everyone.